Hello, I am Srđan Verstovšek. I'm professor of medicine in the leukemia department at MD Anderson Cancer Center in Houston, Texas. Today, I'm going to talk about myeloproliferative neoplasms. And there are many different types of myeloproliferative neoplasms. This is a schema from 2016, a revised WHO classification of myeloid neoplasms. And I'm going to talk about what is in the red color. You see, myeloproliferative neoplasms include essential thrombocythemia, polycythemia vera, and primary myelofibrosis as examples of classic Philadelphia chromosome negative MPNs. And then I'm going to also talk about chronic neutrophilic leukemia and chronic eosinophilic leukemia. In addition, mastocytosis is under my umbrella because it used to be under the box of myeloproliferative neoplasms, and we don't want to give it up. I covered that as well as the myeloid lymphoid neoplasms associated with eosinophilia or MLN-EOs that are associated with certain abnormalities that are kind of taken out of what we used to call hypereosinophilic syndrome / chronic eosinophilic leukemia. So I cover all of this today over 1 hour. And we're going to start with the classic Philadelphia chromosome negative MPNs. These are PV, ET, and MF. I'm going to use these abbreviations. And just a short overview, just to make sure that we are all on the same page, starting with polycythemia vera. Erythrocytosis, I think that's very well known, is a hallmark of this disease, very high red blood cell count, independent growth of erythrocytes, which would, I should also add here, lead to very low erythropoietin level in the blood of the patient. Often, about 60% of patients will have high white blood cell and high platelets. That's why polycythemia, meaning everything grows. Patient may have a splenomegaly and a number of different symptoms related to inflammation and circulation, as listed on the slide. And of course, they're more symptomatic and may tend to have a bigger spleen later in the course of the therapy. As we all know, cardiovascular complications are main problem. About 20 to 25% of PV patients present at the time of the thrombotic event. Important to remember. And the thrombosis is the main cause of death in the polycythemia vera. That's why we typically talk about thrombotic risk assessment. Patients are typically in mid-60s, median survival about 15 to 20 years, which is shy of normal, not completely normal, but it's pretty long. And many consider this condition rather benign. Although it can progress to myelofibrosis and acute myeloleukemia, as we all know. ET is similar to PV, but is just manifested by overproduction of platelets. Occasional patients, to be fair, may have a high white cell count, not too many. And the symptoms and signs of ET are similar to PV, but not as problematic. And a normal life expectancy is expected of these patients, with the fewer patients progressing to myelofibrosis or AML. But also importantly, some patients with ET, JAK mutation positive, and I'll come to that in a minute, can progress to PV. Don't forget that possibility as well. And then myelofibrosis, 2 types of myelofibrosis, prefibrotic without fibers and overt fibrotic disease. This is the one overt fibrotic disease that we usually think of when we talk about myelofibrosis, but there is now also a new entity, a prefibrotic myelofibrosis that is not as aggressive as fibrotic, and I'll elaborate that much today. That disease, myelofibrosis, typically will eventually lead to cytopenias, big spleen, and constitutional symptoms, and shorter life expectancy, with about a quarter of the patients getting into the acute myeloleukemia. Now, everything with the classic Philadelphia chromosome negative MPN has to do with activation of intracellular signaling pathway. A JAK-STAT intracellular signaling pathway is hyperactive. This is the well-characterized signaling pathway in the hematopoiesis, inflammation, and immune function. And these aspects are perhaps important because some of these would then lead to some side effects related to JAK inhibitors. Now, what you see in a cartoon here is the simplified way of looking at this intracellular signaling pathway, and the importance today is to say that the JAK2, and there are 4 family members in the family of JAK enzymes. The JAK2 specifically mediates cytokine signaling for red blood cells and platelets. And in normal person, like I, for example, hopefully go under that, if you would inhibit the JAK2, I would become anemic and thrombocytopenic. important to remember. Now, in the disease, MPNs, classic MPNs, we have abnormalities that lead to hyperactivity. Abnormalities are related to the yellow arrows, are mutation in the cytokine receptor, MPL receptor for thrombopoietin, a JAK2 mutation, which probably we all know about, and then calreticulin mutation, which leads to calreticulin protein to be expelled and attaches itself to the receptor for thrombopoietin, another way of activation of this JAK-STAT pathway. So these are so-called driver mutation, a JAK2 mutation, calreticulin mutation, and MPL mutation that are usually, almost always, but not always, almost always exclusive of each other. And this is how they separate within different entities. In PV, of course, almost everybody has a JAK2 V617F, but few patients may have JAK2 exon 12 mutation, and there is still a possibility to have a PV patient without the JAK2 mutation. That would be LNK or SH2B3 mutation, which we don't usually test for, but that's another possibility in occasional anecdotal case of PV that is JAK mutation negative. Otherwise, in ET and myelofibrosis, as you can see, mutations are spread from the JAK2 to calreticulin to MPL in the order of frequency. And then there are some patients that don't have any so-called triple negative driver mutations patients. We're going to start with PV, and just to highlight the diagnostic criteria, which are not that complicated. A minor criteria in the middle of the slides would say elevated hemoglobin. It doesn't have to be super high, but it has to be accounted for in combination with a presence of a JAK2 or a JAK2 exon 12 mutation and the bone marrow hypercellularity for age with panmyelosis. The three together should be present, or first two major ones, the hemoglobin and the bone marrow with the subnormal serum erythropoietin level, which is common finding as well. This is how you make a diagnosis, not presence on one particular factor, but you have to combine it together. Many ask whether bone marrow biopsy is absolutely mandatory, and it's not, even by the WHO classification and clarification in 2017. You see this at the bottom of the slides, that in patients who have absolute erythrocytosis, super high red blood cell count with the blood test that would show JAK2 mutation and suboptimal serum erythropoietin level, that is probably enough for making diagnosis of PV. But for prognostication, the bone marrow is useful because you can test for fibrosis, and about 20% of patients with PV at the time of diagnosis have already grade 2 and grade 3 fibrosis on a scale from 0 to 3, which is significant prognostically, and some may have chromosomal abnormalities that you can test on bone marrow, which are also prognostically important. Now, what is masked PV? This is more of the clinical term rather than diagnostic term. You may recall that in 2008, the WHO diagnostic criteria for PV mandated abnormally high levels, but that was decreased in 2016, recognizing that some patients present with the high normal, not abnormally high red blood cell count because they're already iron deficient to some degree. And in these patients, if you test for JAK2 mutation in the blood and do the bone marrow biopsy, finding hypercellularity versus normal cellularity in ET, for example, you would then do a very good service to these patients and actually come to a conclusion that that patient with the high normal red blood cell count, JAK2 positivity, hypercellular bone marrow, and typically also low erythropoietin level has a PV. That's why those changes in 2016 diagnostic criteria for PV be cognitive of a possibility that not every single patient with PV have a super high, abnormally high levels of red blood cell count. This is practically valuable and a really good question for a test. Now, what do we do with PV? We go by the prognostication for thrombotic risk assessment. You can see in upper part of the slide, age and history of thrombosis are two factors that, according to the table, will divide the patients in low risk and high risk for thrombosis Everybody is treated with phlebotomy, bloodletting, that would decrease the red blood cell count, and a low dose aspirin to make blood flow easier. High-risk patients are given a cytoreductive therapy, which are typically hydroxyurea or interferon, maybe busulfan for very elderly. That would normalize the blood cell count and eliminate need for phlebotomy. In low-risk patients, there are exceptions when the cytoreduction might be needed, as outlined in the slide. And I would perhaps highlight the platelet number that may be associated with the risk of bleeding. Platelet number is not a risk for thrombosis. Risk for bleeding when the platelet number goes above 1.5 million, when there might be acquired von Willebrand factor deficiency. And one more point here is that iron supplementation is not recommended. People with PV typically become iron deficient to phlebotomy if they're not already iron deficient at the beginning. And that is not to be supplemented unless there is a very good reason, some significant symptoms from iron deficiency. Otherwise, the iron supplementation will just make people require more phlebotomy. The goal of therapy number one is to decrease and maintain as much as possible hematocrit below 45%. No question about it these days. This is prospective randomized study that aim to maintain patients below 45% all the time, as much as possible, versus maintaining hematocrit between 45 and 50. And as you can see in this slide, this is one of the major papers and a good question to ask. In this study, there was a fourfold lower risk of thrombosis and death in people who had a good maintenance of hematocrit below 45%. However, the guidelines would usually extend that control of hematocrit to control of platelets, white cells, spleen, and symptoms, 5 factors to judge the efficacy of cytoreductive therapy. And typically, many times we talk about complete hematological response, where the red blood cells, platelets, and white cells are normalized. And there are a lot of evidence that white cells actually do contribute to that thrombotic risk, unlike platelets. Importantly, we have a new development last fall in November 2021, approval of a ropeg interferon alpha 2B as a full-fledged therapy for PV. The guidelines would say that patients in the United States, NCCN guidelines, patients with PV that require cytoreductive therapy could be given hydroxyurea, standard old-fashioned cytoreductive chemotherapy, or a ropeg interferon, approved based on the study called PEG-INVERA study, where phase 1/2 study, about 80% of the patients were able to achieve complete hematological response, control of the hematocrit without phlebotomy, below 45%, which is the goal, no phlebotomy needed anymore, and normalization of leukocytes and platelets. In the second-line setting, after hydroxyurea, ruxolitinib is approved based on the studies that are shown here. This is, again, in patients who are previously treated with hydroxyurea, resistant, refractory, intolerant. In that setting, second line, in people without big spleen, the study results are in the middle of the table. And in patients with splenomegaly, this is a response study to the right in this table, you can see a very good hematocrit control, and then complete hematological response and improvement in the symptoms. Later in the course of the therapy, people are symptomatic, have big spleen, and uncontrolled blood count. So it's valuable, a second-line choice. And again, very good question on the test. What is the second-line choice after Hydrea? Maybe a case there, and this is the one. Moving on to ET, and I'm going to contrast ET to prefibrotic myelofibrosis that I mentioned before, because some years ago, prefibrotic myelofibrosis has been identified after careful analysis of what we would traditionally call ET patient. Patients with high platelets were reanalyzed, and about 15 to 20% of them, about 10 years ago, were found to have signs of different bone marrow findings suggestive of a pending progression to myelofibrosis, and this is called prefibrotic myelofibrosis. So to compare the two, I see here in the orange ET, high platelets, normal cellular bone marrow, no fibrosis of significance, and of course, no other disease, and a presence of one of these driver mutation. If you look to the right, this is prefibrotic myelofibrosis. Typically, again, patients present with high platelets, but the bone marrow is hypercellular, no fibers, and they have one of the other driver mutations. So some differences in the bone marrow. And what can then help is what is listed under the minor criteria in red color. Prefibrotic myelofibrosis also may have a little bit of anemia, leukocytosis, splenomegaly, or elevated LDH. So this is how you make a difference between the two, but they do overlap a lot in everyday practice. What do you do with patients with ET? Historically, you would divide the patients in low risk and high risk for thrombosis, as I see on this table, the same two factors that we discuss about PV. Hydroxyurea is a front line. Anagrelide is there as a second choice, and interferon is also listed as a possibility. Platelet number, as I pointed out in PV, is not a risk factor for thrombosis. You worry about extreme thrombocytosis, which is associated possibly with acquired von Willebrand factor deficiency. You can test for it, and then you can perhaps consider cytoreductive therapy in low-risk patients with such extreme thrombocytosis. But remember, the high platelets are not a risk factor, and there is no need in a low-risk patients otherwise to institute cytoreductive therapy to proactively lower the platelets to prevent the thrombosis. That has been studied in prospective randomized study. This is a very good test question, right? The patients that were younger than 60 without the high-risk features were randomized between the observation or hydroxyurea. Hydroxyurea lowered the platelets, as you would expect, but there was no benefit whatsoever. So proactive cytoreductive therapy to lower the platelets and prevent thrombosis does not really have a role in management of patients with ET that are low risk. Further clarification of the prognostication happened recently, and realizing that patients with a different driver mutations have different risk of thrombosis. As you see in this slide, in the graph, calreticulin positive ET patients have fewer episodes of thrombosis, very low thrombotic risk versus others. JAK2 is the most common one, that is the most common that is tested for. And that's why new prognostic scoring system for thrombosis is now in place. This is, again, a very good test question. You would see in this table at the lower part, the old high-risk patients, remember age over 60 or history of blood clot, is now modified. The patients that are older than 60 and don't have a clot and don't have a JAK2 mutation are only treated with aspirin. So who is the high-risk patient? Patients that have a history of thrombosis, or patients that are older than 60 with a JAK2 mutation. Please remember, this is a very good test question. The number of patients that require cytoreduction therapy has decreased because of new guidelines. What is then prefibrotic myelofibrosis? Comparing this to ET, what you see on the left side is the survival of the two groups. This is one of the seminal papers that describe this group of people. You see that patients with early prefibrotic myelofibrosis, looking to the left, have a median survival of 15 years. And if you look to the right, these patients in a gray color with prefibrotic myelofibrosis have about 15% chance of getting to fibrotic stage at 15 years, and about 10% in the right lower part, 10% risk of AML after 15 years. I call this my own rule of 15. Easy to remember for management and for the testing when it comes down to prefibrotic myelofibrosis. All right, if we have on the left side of this slide, prefibrotic early stage myelofibrosis, which we do manage as ET, because that is how they present with high platelets most of the time, with typical survival of 15 years. Then we're going to move on to the progressive or fibrotic, overt fibrotic myelofibrosis, which can be primary or secondary to ET and PV. These people have bad quality of life, big organs, spleen and liver, and bad bone marrow function with cytopenia. So these are the three main reasons why we treat these patients: for symptoms, spleen, and anemia, I should say, progressive cytopenia, typical anemia. A quarter of them goes to acute myeloid leukemia, but others progressively get weaker and die from myelofibrosis-related complications after 5 to 7 years. So how do you make a diagnosis of this one? The fibrotic myelofibrosis have fibers, grade 2 and 3 on a scale from 0 to 3, and not other disease, of course, with what is listed in the middle of the slide: anemia, leukocytosis, splenomegaly, high LDH, and unlike any other disease, leukoerythroblastosis. That's the difference here, versus prefibrotic myelofibrosis, for example, higher grade, and leukoerythroblastosis. So this is diagnostic criteria for fibrotic myelofibrosis. And in myelofibrosis, we have a prognostic scoring systems that are useful to assess the risk of dying, with the primary goal to identify patients that have a life expectancy less than 5 years. Then they would go to the transplant. That's the primary goal why we prognosticate. And here is the one of the simplest prognostic scoring systems, the first one which was developed at the time of diagnosis to be applied in primary myelofibrosis patients. And you can see in a table in the left upper corner, the age, symptoms, hemoglobin, that means anemia, high white cell count, and blast in blood. Probably do not need to remember that because there are many other prognostic scoring systems. I'll explain this in a second. But just to give you a perspective that at the time of diagnosis, you can divide patients in 4 groups, as you can see in this graph, and only one factor would already advance the patients from low to intermediate 1 group, and the life expectancy would be different. Unfortunately, in the table in the left lower corner, the overall survival in years should be the opposite. Low risk is 11, intermediate 1 is 8, intermediate 2 is 4, and high risk is only 2, just to be right. Since that, more than 10 years development of that prognostic scoring system, we learned that the presence or absence of different driver mutations in the circles in this slide carry a different prognosis. And perhaps to remember, in blue, in a purple color, calreticulin positive patients have the best outcome. Many these days test for other possible mutations by NGS, which has nothing to do with the activation of JAK-STAT pathway. These are somatic mutations that may contribute to the aggressiveness of the disease. Some of this is outlined in the lower part of the slide. Some of these mutations are so-called high molecular risk mutations. And based on that, including the cytogenetic abnormalities that may be present in up to 40% of patients, there are many new prognostic scoring systems. I don't think they will be asked in the testing. And there is real choice among the prognostic scoring systems listed in NCCN guidelines for one to choose from. So not to dwell much more on that, let's go to the management. Symptomatic burden is high in patients with myelofibrosis, and this is one of the main reasons why we treat the patients. Remember, symptoms, general systemic symptoms, as you can see here, symptoms related to big spleen, so organomegaly, which is symptomatic, and then symptoms related to anemia typically. And to objectivize that, NCCN guidelines would highly recommend one to use MPN-10, which is the questionnaire that tries to objectivize those symptoms and certainly helps in management of the patients. And it may be a question on the test, how to objectivize the quality of life, which is now endorsed so much by the NCCN guidelines. Now, what do we do then in everyday practice? This is simplified NCCN guideline. If we go from the left to the right, first in a purple boxes are lower risk and high risk, meaning a risk of dying, right? First, you prognosticate, and you have, again, in lower part of the slides, multiple abbreviations of different prognostic scoring systems. You choose one and you go about prognostication and referral to transplant. Then you move from the left to right and see about the symptoms. That's why I talk about MPN-10. Symptomatic patients should be treated for the symptoms. And if they're lower risk, they're probably not that sick. You can use ruxolitinib, as it says on the in the middle of the slide. In proliferative phase, ROPEG interferon or pegylated interferons and hydroxyurea. In the high-risk patients that are sicker, usually advanced, you have a JAK inhibitors here, ruxolitinib, fedratinib, which either one are approved therapies for patients that have a platelets above 50. And more recently, pacritinib was approved in the earlier part of this year as a therapy for patients with platelets below 50. Importantly, no JAK inhibitor is selective for the JAK2 mutation. They inhibit the JAK-STAT pathway, not the JAK2 mutation, and they're useful in any patient, regardless of a driver mutations that have hyperactivity of JAK-STAT pathway, which would be basically any patients with myelofibrosis, as well as PV and ET when it comes to that fact. What do JAK inhibitors do? they improve the spleen and symptoms. Simple, I think, widely known. Here is a study that compared ruxolitinib to best available therapy. By the way, best available therapy was hydroxyurea. And these are waterfalls on the achievement of a spleen reduction from 0 going down. Each vertical line is one patient. So very much effective to a different degree, ruxolitinib, and not much effective best available therapy. And you see photos of one of my patients. You can appreciate the spleen reduction and quality of life improvement. The main concern with the ruxolitinib specifically is anemia and thrombocytopenia, which are on-target toxicity with this drug, and one needs to balance between the myelosuppression and benefits on spleen and symptoms. Importantly, in United States, since 2014, on the label for ruxolitinib, it says that it prolongs survival. From these studies that led to its approval, there was a convincing evidence to the FDA and to investigators in the field that the drug, by controlling signs and symptoms, makes people live longer. Important for everyday practice and as a test question is what happens if you suddenly stop a JAK inhibitor in people who are responding. Remember, it's anti-proliferative and anti-inflammatory. So the cytokines, the inflammation is part of the disease. That's why people don't feel well, are controlled well with JAK inhibitors. And as it's known for ruxolitinib and written in the FDA description of its abilities and side effects, when you stop it cold turkey in people who are responding, the symptoms come back within 7 to 10 days. Excellent test question, I tell you. So avoid interruption because if that happens, what do you need to do? You need to give it back. Or better, if you need to stop it, taper it off and have a steroids ready to counteract that rebound in the cytokines. So be aware of that. It's not extraordinarily common, but it does happen, and people may get in trouble when you stop it cold turkey. Fedratinib is another JAK inhibitor approved for the same or similar indication as ruxolitinib for intermediate 2 and high-risk patients. And if you look to the left, this is the study that led to its approval for intermediate 2 and high-risk patients in the first line. No comparison here to ruxolitinib. Unfortunately, we don't have that. It was placebo-controlled. And fedratinib at the dose of 400 milligrams daily has been approved based on ability to help about 37 to 40% of patients by this official response criteria. Again, most of patients improve. This is the drug that is given as a single dose for any patients with platelets above 50. Remember, for ruxolitinib, you have to adjust the dose based on the platelet numbers. In the NCCN guidelines, fedratinib is also listed as a second-line choice. Basically, it says that you can use one after the other. And there is a good data here from the phase 2 open-label study of fedratinib patients that were resistant and refractory to ruxolitinib, about 30% response rate in that setting. Is there any other difference between the two drugs? Yes, toxicity profile is different. Fedratinib will cause some anemia and thrombocytopenia, which is in the red box in the lower part of the slide, to about a similar extent as ruxolitinib, but it also causes some diarrhea, vomiting, and nausea, which is in the red box in the upper part of the slide. So it is mandatory, I would say, remember, to inform the patients and be cognizant of possibility of causing some diarrhea, vomiting, and nausea, and give a patient prophylactically or to have it ready there, some medications for these problems, so that the patients do not stop the therapy, because that's what happens right at the beginning. It does not cause discontinuations, but one needs to know about it. And the other difference is on the right side, the black box warning, extremely rare complication with fedratinib, Wernicke encephalopathy, which develops because of interference of uptake of thiamine by fedratinib from the GI tract into the body of the patients. They're structurally similar. That does not happen with any other JAK inhibitor. And then the thiamine deficiency can cause Wernicke encephalopathy. A good test question. Remember that. What do you need to do? Measure thiamine before you give fedratinib, and on therapy, periodically check. And of course, if it's low before or during therapy, supplement it so you don't have any issues like this. And then pacritinib, approved recently in February of this year for patients with platelets below 50, again, intermediate and high risk. from a study which compared pacritinib to best available therapy in patients with platelets below 100. This is the result is on the right side. This is the study that compare these two groups, pacritinib versus best available therapy. Best available therapy did include in about 50% of patients ruxolitinib. Remember, ruxolitinib is used at the lower dose here. It's not that effective, and this is a testament of benefit to pacritinib. The label says it's for patients with platelets below 50. The subgroup is analyzed to the right. So 26 to 29% response rate with pacritinib is expected, and it's better, as you can see, than conventional best available therapy in these patients. This is why this drug was approved in accelerated way. The phase 3 randomized study is underway in patients with platelets below 50, comparing pacritinib versus best available therapy. It's global, but we already have ability to prescribe pacritinib, so please remember that. What do we do about anemia? Anemia can be a consequence of the therapy, we said with some of JAK inhibitors. Unlike, I should say, with pacritinib. Pacritinib is approved for patients with lower platelets below 50 because it's not myelosuppressive. But if anemia is there, whether it's drug-related or disease-related, I should say most of patients would develop it over time. We would first check the EPO level, erythropoietin level, and if you can see this NCCN guideline, it's lower, then try erythropoietin stimulating agents for a few months. Otherwise, we would use danazol or prednisone or IMiDs really in every practice. Now, none of this is approved for therapy, but it's used and listed in the guidelines, NCCN guidelines, as useful in patients with anemia. And it can be combined, I should say, from my own perspective, with the JAK inhibitors for sure. What happens if the disease progresses in terms of blast? Remember, about a quarter of the patients will eventually end up with acute myeloid leukemia. Acute myeloid leukemia is then is the most frequent or most deadly complications of myelofibrosis. And we all fear about it. Also, on the other hand, most people die from myelofibrosis itself. In management of patients with higher blasts, we now recognize accelerated phase, right? So in the middle of this slide, you have MFAP. Accelerated phase is patients that have a blast between 10 to 19%. And of course, blastic phase is 20% or more. What you can appreciate here is that we don't wait for the blast to go above 20. We start therapy when the blasts are above 10. And what we do, if the patient is transplant candidate, we try to first apply hypomethylation agents, HMAs, which are azacitidine or decitabine. They appear to be about the same effectiveness as is with the intensive chemotherapy. Only then, if HMAs don't work, we go to intensive chemotherapy, followed immediately by the transplant. If the transplant is not a possibility, which unfortunately is most of the time, we do not do intensive chemotherapy anymore. The HMAs, hypomethylation agents, or low-intensity chemotherapy are the norm. Perhaps even good test question for people who are not transplant candidates that are having more than 10% blast. Hypomethylation agents are the norm, and the JAK inhibitors can be continued for control of the symptoms. We, for example, use 10 milligrams twice a day of ruxolitinib without changing the dose, because the blood count will be lower in these patients because of use of hypomethylation agents. Moving on to other atypical Philadelphia chromosome negative MPNs, and I'm going to start with hypereosinophilia. It appears complicated, but it is not really that complicated at all. If you just go from the top of the slide down, you would certainly, in people who have hypereosinophilia, look for other causes, allergic type of reactions, parasitic infections, for example, and then you would screen for certain abnormalities. This would be cytogenetic and molecular abnormalities. Cytogenetic in particular, in the middle of the slide, which would identify rare diseases that we called myeloid lymphoid neoplasms with eosinophilia. They are driven by different abnormalities, which I will explain in a minute. If they are not present, then we look for clonality marker of other types, which would then identify patients with chronic eosinophilic leukemia, which is straight down from the top to the bottom. and look for abnormalities in T cell receptor rearrangements, which would then identify lymphocyte variant hypereosinophilia, which are subject to different therapies like immunosuppressive therapy and may have a tendency to develop into the lymphoma. So, of course, at any point in time, you worry that eosinophilia is a marker of some other disease in the bone marrow, and complete workup is absolutely necessary. Talking about this lymphoid myeloid neoplasms with eosinophilia, I'm going to start with one. This is absolutely crucial to remember for practice and for the testing, and this is the one that is driven by PDGFR alpha, platelet-derived growth factor receptor alpha, which is super sensitive to imatinib, 100 milligrams a day. What do you do about it? It's an abnormality in chromosome 4q12, as you can see. Deletion of region of about 800 kilobases are removed, and that is not visible by cytogenetic abnormality, but it's visible by FISH. That's why I have a FISH in the right upper corner of this slide. What happens with this abnormality? Two genes come together, PIP1L1 and PDGF alpha, which activates PDGF alpha and drives the disease process. So this test, also it's not cytogenetic test, it's a FISH test, or even PCR for active PDGF alpha as alternative, are crucial in workup for eosinophilia. So this is very rare. We thought at the beginning when this was first recognized that it's very common, but it's not. It's usually in younger males. And importantly, it's not visible by standard cytogenetics, but FISH or PCR are the standard practice tests that are readily available, because when you identify that, you have a high probability with imatinib 100 milligrams a day, low dose, to eliminate disease, and the relapses are extremely rare, right? So this is obviously a test question. Resistance mutations do happen, but again, this is less than 20 cases in the world ever. So very important to remember. The other myeloid lymphoid neoplasm with eosinophilia is driven by platelet growth factor receptor beta. Now, this one is actually seen by looking at the chromosomes, because not too many centers have a FISH for PDGF alpha beta. This is chromosome 5q33. So standard karyotyping will usually identify that, and when you see that, typically that would be translocation 512, most common among these ones, translocation 512. That would be indication of possibility having activation of PDGFR beta. A FISH for that exists in some academic centers, and it's a possibility. Very rarely PCR also exists, but of course, it is very important to test for, because imatinib, again, at 400 milligrams daily, is approved and effective therapy to eliminate disease in these patients. And finally, something completely new. This is a third of these myeloid lymphoid neoplasm with eosinophilia, one extremely rare, which is driven by activation of FGFR1, fibroblast growth factor receptor 1, which is seen by, again, cytogenetically visible reciprocal translocations activating the gene at 8p11. So historically, we would call this 8p11 MPN syndrome, but the disease can present as acute leukemia, myeloid or lymphoid or lymphomas. Be aware of the variety of possibilities, but the unifying abnormality is translocations that activate FGFR at 8p11. A good question. And now, since a few weeks ago, we have a drug approved called pemigatinib as a therapy for this particular entity, which is FGFR1 inhibitor, and achieves about 80% of patients eliminating disease, achieving complete cytogenetic response. Last of these myeloid lymphoid neoplasms is the one that does not have a possibility of being eliminated, but the JAK2 rearranged MPL eosinophilic condition that activates the JAK2 at chromosome 9p24 can be subject to ruxolitinib, a JAK inhibitor. So any of these very rare conditions have therapies, and some are extremely effective, like imatinib or pemigatinib, in eliminating disease. How do we come by with the to say somebody has a chronic eosinophilic leukemia, then it's a blue color, the second bullet. Of course, you have high eosinophils. And then there is some other cytogenetic molecular abnormalities, not the one that I talked about, or a blast 2 or more in the blood or more than 5 in the bone marrow. And of course, no other evidence of any other disease at all. This is, at the end, chronic eosinophilic leukemia. How do you go about therapies? First, of course, reactive treat underlying cause on the left. Then remember imatinib for alpha and beta rearranged, PDGF alpha rearranged MPL-EO, pemigatinib for FGFR 8p11 syndrome, JAK2 rearranged 9p24, ruxolitinib, and then the variety of other agents. This is a nice summary for therapeutic purposes. Chronic neutrophilic leukemia. Well, neutrophils are high, obviously. White cell count is very high, about 25, with most of them being sex or bands, and less than 10% immature. Hypercellular bone marrow, a lot of normal neutrophils, and nothing else causing it. So a lot of neutrophils, very high white cell count, and certainly a good test question. If it's not for practice, which should be, you will see why. This is the photo of the bone marrow and blood. Perhaps something to remember. That would be a good test question, I'm sure. What happens in this condition most of the time, but not always, is the activation of colony-stimulating factor 3 receptor, or CSF3R. This is leading to, again, a JAK-STAT pathway activation. And of course, then ruxolitinib or any JAK inhibitor should be considered as a therapeutic option. So remember, CSF3R mutations, chronic neutrophilic leukemia, very high number of white cells, almost all of them neutrophils. What can be done to target the underlying cause, if you like, hyperactivity of JAK-STAT pathway? In many patients, ruxolitinib can be effective. This mutation spills over from chronic neutrophilic leukemia to atypical CML. I don't cover much atypical CML, that's different topic, but I want to give you perspective that it's important to recognize that clinical entities that are similar to each other do sometimes share some of these mutations. So on the left side, CNL, 83% of the patients would have it, and atypical CML about 8%. So in those cases, it's always useful to test for it, and then you have a chance to control the proliferation and inflammation with JAK inhibitors, not to eliminate it, but control it, because there is no specific mutation inhibitor for this disease. And moving on to mastocytosis, another very good pictures here, which may lead to a test question. This is mastocytosis, as you can see, with these clumps or groups of the abnormal mast cells in the bone marrow. It's not evenly spread. It's not evenly spread in the involved tissue. This is how it looks, and these cells produce tryptase. Active mast cells would produce a lot of tryptase. That's one of the markers of the disease. And of course, they have on their surface the CD117, which is a KIT receptor for the stem cells, which is a stem cell factor, which is the growth factor for the mast cells. So this can be associated about 40% of the time with the skin involvement. The systemic mastocytosis that involves the bone marrow and organs may be associated with the skin disease. And many times I have seen the presentations of the skin like this, leading eventually to a question of, hey, why is that a patient's also anemic? And then you put 2 and 2 together. So I tell you, a very good test question, but it's also important for everyday practice if you see patients with this type of skin changes. So how do you make a diagnosis? Involved tissue, which is not the skin, because there is a skin mastocytosis on its own. So non-skin disease, extracutaneous tissue, would have mast cell aggregates, those pictures that I showed you, of 15 cells or more. That's the mandatory, basically, major criteria in most of the practices to diagnose the disease. And then the minor criteria are spindle-shaped. They're not circular, nice. They're spindle-shaped. And the genetic testing for mutation in that receptor, KIT receptor, which is KIT D816V, present in majority of the cases. some abnormalities in other proteins on the surface. You do the flow for CD25 and CD2. So you have CD117, CD25, CD2 T cell markers. If you have all of this in one cell, that's a malignant mast cell. And they produce the tryptase. So some requirement for thinking about the diagnostic process. It's not that simple. And you need to have one major and one minor criteria or three minors to make a diagnosis. Then, once you have a diagnosis, you see a patient say, the patient has the disease that affects the organ function or not? If the organ function is not affected, then the patient has, in lower part of the slide on the left side, indolent disease. This is majority of the patients have indolent systemic mastocytosis that hardly ever would progress to advanced. Advanced is the one that affects the survival and is manifested by organ malfunction. And you have here some patients that have pure aggressive systemic mastocytosis with impaired organ function, patients that have mastocytosis with associated non-mast cell hematological neoplasms, most of the time CMML or MDS, and then mast cell leukemia, which is extremely rare, where you have mast cells in the blood, or on the aspirate, you have more than 20% mast cells on aspirate, not on a biopsy. So this is advanced systemic mastocytosis, which is something that hematologists would see, but in the spectrum of the frequency is not as frequent as it is indolent systemic mastocytosis. And we're going to focus on advanced disease for which we as hematologists have a therapies. Midostaurin is a specific KIT D816V inhibitor. The first one that was approved for advanced mastocytosis. I use this term advanced, which is aggressive systemic mastocytosis with associated hematological neoplasms and mast cell leukemia. Among these, as you see, the most frequent one is the one that has associated non-mast cell hematological disease. But never mind, the midostaurin is effective therapy in controlling the symptoms and signs of the disease in many of these advanced systemic mastocytosis patients. Typically works for about 2 years in clinical studies at least, but it does not provide such the bulking of the disease as we would like. If you look to the left side, complete response is not common at all. I should also say this is something not to overlook, especially for the test, that imatinib or Gleevec is approved for adult patients with aggressive systemic mastocytosis that do not have KIT D816V mutation, or the mutation status is unknown. This happened many years ago, and it is true that not every single patient have a KIT D816V mutation. If it's negative, then a mutation might be in other part of the gene for KIT, which may be then sensitive to imatinib. So consider that as a therapeutic option for mastocytosis as well. It's not common at all, but it's good to know because it can eliminate disease. And more recently, about a year ago, avapritinib was approved, another KIT D816V inhibitor, which appears to be more effective than midostaurin, although we don't have a head-to-head comparison. But just by looking what I'm showing here in the circle on the left side, complete remission or partial remission and percentages that follow give you a perspective that this might be a useful drug in your management of patients with advanced systemic mastocytosis. So midostaurin and now avapritinib are approved therapies for systemic mastocytosis. Remember, imatinib for those that do not have a KIT D816V mutation, right? So essentially, you may say 3 drugs approved for systemic mastocytosis, advanced systemic mastocytosis patients. This drug, avapritinib, is used at the 200 milligrams once a daily dose, and it's not to be given to patients that have a platelets below 50 because of some reports of increased bleeding. So not for patients with platelets below 50. So I want to thank you very much for your attention. I hope this was useful to you. These are my contact information. This being a review for a specific purpose, I certainly did not go in the details of the management of the patients. I would be happy to help in any possible way to that regard. This is my email. Please send me emails anytime about any MPN related question. Thank you very much.